Hello, everyone. My name is Michael Mensa, and I'll be introducing this next episode of the Health Justice Seminar Series in the Lancet Commission on U.S. Public Policy and Health. This session is titled Reparations in Health, and will be paneled by Professors William Sandy Darity Jr., PhD, Distinguished Professor of Public Policy at Duke University, as well as Kayty Himmelstein, MD, Infectious Disease Fellow from Harvard Medical School, and will be moderated by Claudia Fegan, Chief Medical Officer of Cook County Health. This series intends to bring experts and activists together in order to share ideas and formulate possible solutions to these long-lasting problems and issues that have impacted health, and examine these issues from a social science lens. I will now turn it over to the moderator, Claudia Fegan, to continue the discourse.
Thank you. Good afternoon, everyone. William A. Sandy Darity is the Samuel Du Bois Cook Professor of Public Policy, African and African American Studies and Economics, and the director of the Samuel Du Bois Cook Center on Social Equity at Duke University. Darity's research focuses on equality by race, class, and ethnicity, schooling and the racial achievement gap, North-South theories of trade and development, skin shade and labor market outcomes, the economics of reparations, the Atlantic slave trade, and the Industrial Revolution, the history of economics and the social psychological effects of exposure to unemployment. His work with Kirsten Mullen, From Here to Equality, Reparations for Black Americans in the 21st Century, advances a general definition of reparations as a program of acknowledgement, redress, and closure. Acknowledgement constitutes the culpable party's admission of responsibility for the atrocity. Redress constitutes the acts of restitution, the steps taken to heal the wound, and closure constitutes an agreement by both the victims and the perpetrators. The account is settled. Kayty Himmelstein is a researcher and fellow in infectious diseases at Massachusetts General Brigham, as well as a co-author of a recently published Hospitals That Serve Many Black Patients Have Lower Revenues and Profits, Structural Racism in Hospital Financing in the Journal of General Internal Medicine. Dr. Himmelstein is a member of the National Working Group of White Coats for Black Lives and a passionate advocate about issues of equity. I am Claudia M. Fegan. I am the Chief Medical Officer for Cook County Health and the National Coordinator of Physicians for a National Health Program, as well as Vice President of Health and Medicine Policy Research Group. We will each speak on the subject and then we'll entertain questions. So we'll start with Dr. Darity. Sandy?
Thank you so much. And I'm really, really honored to have the opportunity to speak on behalf of this Lancet Commission. I'd like to begin by sketching a particular and specific program of reparations that will inform the rest of the conversation that I would hope to engage in today. There are four dimensions of the reparations plan that Kirsten Mullen and I advance in our book, From Here to Equality. The first is we establish criteria for eligibility. And we contend that the eligible population should consist of individuals who are Black American descendants of persons enslaved in the United States. To identify that eligibility status, we propose two conditions. First, a lineage standard, where an individual would have to demonstrate that they have at least one ancestor who was enslaved in the United States of America. And second, an identity standard. So this would mean that for at least 12 years before adoption of a reparations plan or a study commission for reparations, an individual would have to self-identify as Black, Negro, African American, or Afro-American on an official document. We propose that this is the population who should be eligible for reparations because this is the community that has borne the weight of American racism from the start of the Republic to the present moment. In addition, these are individuals who are descendants of the freedmen who were promised 40-acre land grants as restitution in the aftermath of the period of enslavement in the United States, and who, in fact, received absolutely nothing from the federal government. The second condition or characteristic of a reparations plan, and this is going to be extremely relevant to the issues that we're going to explore today, is the objective of a reparations plan, which is to eliminate the racial wealth gap. The black-white chasm in wealth is the premier economic indicator of the cumulative intergenerational effects of white supremacy. This gap is driven by the racially uneven intergenerational transmission of resources. Why are those resources unevenly distributed in such a way that one community has considerably less to endow subsequent generations with? It's precisely because of an array of United States government policies. One of these policies I've already mentioned, which was the failure to provide the newly emancipated with the 40-acre land grants that they were promised. But at the same time, the federal government was providing 1.5 million white families, including recent immigrants from Europe, with 160-acre land grants in the Western territories as the nation completed its colonial settler project. And these 160-acre land grants were provided under the auspices of the Homestead Act of 1862. This was the beginning point in the aftermath of slavery of the racial wealth gap. Second set of policies were associated generally with government inaction, but occasionally with complicity, associated with the 100 massacres that took place between the end of the Civil War and World War II. These were massacres in which white terrorists not only destroyed Black lives, but also seized and appropriated Black-owned property, furthering the racial wealth gap in the United States. In the 20th century, the federal government makes a transition from asset building via land allocation to asset building via supporting home ownership, but it does so in a highly discriminatory fashion. The discriminatory dimensions of the home ownership subsidy projects include redlining as a successor to restrictive covenants, and also the discriminatory application of the GI Bill for returning veterans from World War II in such a way that white home ownership was heavily promoted to the extent that it built a white middle class in the United States, while Black home ownership was truncated and deprived. And then the final set of policies that I'd like to refer to are policies that emanated from approximately the late 1950s, early 1960s, the combination of the expansion of the federal highway system and alleged slum clearance activities. These resulted in the destruction of Black neighborhoods and the destruction of Black business districts nationwide, and so as a consequence, reinforcing the racial wealth differential. Now, how large is this racial wealth gap today? Well, if we use the data from the 2019 Survey of Consumer Finances that's generated by the Federal Reserve, we find that the average Black household has $840,900 less in net worth than the average white household. If we were to equalize household wealth, we would also be equalizing wealth across individuals, and as a consequence, we would owe the 40 million eligible recipients of reparations approximately $350,000 apiece. This in turn would amount to a total of approximately $14 trillion, which would be the minimum amount that would be required for a reparations plan. But it would be the amount that would eliminate the racial wealth gap in a direct fashion. So in the discussion that follows, the effects of reparations on health outcomes will be treated as the effect of elimination of the racial wealth gap. Now, there's a third aspect of the program of reparations that Kirsten Mullen and I have advanced, which is to answer the question of who's responsible for paying this substantial debt. And it's the federal government. States and localities cannot do it. Their total budgets amount to less than $5 trillion, while the federal government definitely has the capacity to meet a bill of any size, as long as it structures the expenditure so that it minimizes the risk of inflation. And one of the things that we attempt to do in our book, From Here to Equality, is propose ways in which this can be done. The fourth and final characteristic of the program is to determine exactly how the payments should be made. And we argue that it should be direct payments to the individual recipients. Now, in terms of the whole question of the relationship between reparations and health, let me start with the observation that we now have, and this has been an important development over the course of the past 25 years or so, we now have a significant emphasis on trying to understand what people refer to as the social determinants of health. And one of the critical aspects of this is an individual's socioeconomic status. This typically is measured by looking at income, education, or occupational status. And for the most part, the wealth condition of households or individuals is omitted from the calculus. I would argue that it's critical to integrate the analysis of wealth differentials into our understanding of health differences, because the racial wealth gap provides us with a wonderful, and perversely, but a wonderful index number to capture the notion of structural racism. Now, Zinzi Bailey and her co-authors observed that structural racism can be defined as the totality of ways in which societies foster discrimination via mutually reinforcing inequitable systems. For example, housing, education, employment, earnings, benefits, credit, health care, criminal justice, that in turn reinforce discriminatory beliefs, values, and distribution of resources. Now, I would like to submit that the wealth gap encapsulates these effects. It brings them together in terms of a single measure that gives us a sense of the degree of disparity in American society. Research is now underway on the best way to measure structural racism, but I'm going to propose now that one of the very strong ways to do so is to look at the racial wealth gap. Now, of course, there's a distinction that has to be made between causation and association. And earlier research tend to look unidirectionally at the effect of health outcomes on wealth. More recent research has reversed the causal path. Indeed, some sets of studies look at past generations' wealth and its effect on the younger generation's health. And via the use of other types of longitudinal data, current studies are now examining an individual's earlier wealth position and how that has influenced its individual's health outcomes in subsequent years. One of the most important studies of this type is one by Bean, Keister, and Aronson, using the panel study of income dynamics, where they look at the relationship between net worth and several categories of health outcomes: self-rated health, chronic conditions, work limitations, disability risks, psychological distress, and body mass index. They find that Blacks have worse outcomes across self-rated health, chronic conditions, diagnosed conditions, and disability. But they also find, and this is the important dimension of their study, is that white participants have 7 times greater net worth than the white respondents to the survey. They had greater home equity, greater savings, and greater levels of stocks and bonds. Now, they also do carry more debt, but they were also 2 times as likely to own a home. Interestingly enough, in this same study, Bean and her co-authors examine specific categories of assets and debts and their implications for health outcomes. So aggregate debt leads to worse health outcomes, although in their study, they don't look at specific categories of debt. But in looking at specific categories of assets, they find, for example, that home ownership has a positive effect on health outcomes, but home equity actually has no effect. Subsequent studies have also demonstrated that higher levels of wealth reduce mortality risk. So how do we connect reparations to health? Well, the implication of what I've suggested about an appropriate reparations plan is to say, let's look at the impact of eliminating the racial wealth gap on racial health differentials, or the connection between the racial wealth gap and the racial health gap. In a study that I participated in with Eugene Richardson and James Johnson as the lead researchers, we examined the implications of reparations for the effect of on COVID-19 transmission, and set up a simulation exercise in which we tried to explore what the consequences would be of having a situation in which there was no racial wealth gap in the United States. And we found that we could estimate that there would have been a 31 to 68% decline in transmission rates of COVID-19 across the entire population had we no racial wealth differential. And the last thing I'd like to mention in this context is the fact that Kayty Himmelstein has led a team in producing a study that attempts to look at the consequences of elimination of the racial wealth gap on health outcomes that are related to the pandemic. And I assume or hope that she will talk about that study a bit in her remarks. Thank you.
Thank you so much, Dr. Darity. And you are absolutely right. So I'm going to be using slides, so I will just pull those up for folks' reference. All right. As Dr. Darity referenced, I'm going to be speaking a bit about the health outcomes, a bit more than he has about the health outcomes associated with reparations. And I'm also going to be talking about two other types of wealth or resource redistribution within healthcare that are not reparations in the sense that Dr. Darity has defined them, but are another mechanism or other mechanisms by which we need to think about redistributing resources within healthcare in order to promote health equity and justice. So first, this is the data from the study that Dr. Darity just referenced, on which he is a co-author, which is wonderful. And we also worked with Dr. Morse and a number of other folks who are on this call who made really valuable contributions. So this was a study in which we looked at survival among middle-aged adults. And you can see the data here. So the blue bars are white adults and the orange or yellow bars are Black adults. And in the cohort that we were using, we found that, as we know, Black adults had poorer survival as a consequence of poorer health. We then modeled reparations in precisely the way Dr. Darity described them. So a wealth transfer adequate to close the racial wealth gap, which we modeled in our study on a household level as $800,000 per household. And what we found is that such a wealth transfer, reparations, would significantly close, and in some cases even eliminate, the survival gap. So you can see that in survival to age 65, the gap was entirely closed, and to older ages, significantly attenuated. So this was a modeling exercise based on a wealth transfer equivalent to the size of the racial wealth gap that found there would be significant improvement in Black-white mortality gap. So this was sort of the major finding of that study. And this is modeling reparations as an intervention on racialized wealth inequality. But as you can see from our findings, that alone would not be adequate or sufficient to fully close racial health gaps. And there's certainly a lot of policies in addition to reparations that we could think about. And what I'd like to turn attention to now is other aspects of unequal racialized wealth distribution in the United States. So in addition to the unequal wealth distribution among households and individuals, I think all of us who work in healthcare also recognize that there's unequal healthcare facilities and lower reimbursement for the care of Black individuals. So I'd just like to take a moment to talk about those as well. Here we have photos of two hospitals. I'm an infectious disease fellow at Massachusetts General Hospital, and our $400 million Lunder building is the photo on the left. On the right, we see a photo of Kearny Hospital, which is another hospital here in Boston, about 9 miles away. And at Mass General, about 5% of the patients we see are Black, and at Kearny Hospital, over 40% of the patients are Black. And I think the photos really suggest the different levels of resources and resource investment in the two hospitals, and that tracks very closely with the patients that the hospitals serve. And that's because, as we know, although segregation, formal legal, de jure segregation of hospitals has been illegal for some time, and that's what was being protested in this photo. In fact, our hospital system our healthcare system remains highly segregated in the United States. For example, in the US, about 3/4 of all Black infants are born in only 1/4 of the hospitals. So in fact, our hospitals remain extremely segregated. And so this was a study that I participated in, where we looked at actually quantifying what is that resource inequity between hospitals that predominantly serve Black and Latinx patients and those that predominantly serve white patients. And to do this, we looked at the top 10% of hospitals in terms of those caring for Black and Latinx patients. And what we found is that the capital resources, so the value of the land, the buildings, the equipment that was owned by the hospitals was drastically different. So you can see that for every dollar that in capital and resources that a white serving hospital had, Latinx and Black serving hospitals have less than 70 cents for the dollar. And then perhaps even more troubling, we then looked at new investment and found that new investment in white serving hospitals continues to be much higher, so that this gap in resources is going to continue to grow. And that gap in resources corresponded to less materials to actually provide care. So we looked at a number of capital intensive services, and what you can see here is that hospitals serving Black and Latinx patients were less likely to have advanced imaging technologies like MRI and PET scan, less likely to have surgical technologies like robotic surgery, cardiac surgery, and bariatric surgery, and perhaps most troublingly, less likely to have emergency life-saving services like cardiac catheterization labs. So those differences in resources mean that those facilities are less able to provide care to Black patients. And that's a reflection of multiple policies, including sort of block grants and investments in hospitals, but also a reflection of our payment system. So here we looked at reimbursement for the care of Black patients, or for the care of patients, I will say, at predominantly Black serving versus predominantly white serving hospitals. And what we see is that the reimbursement for care is much lower for hospitals that are predominantly serving Black patients. And as a consequence, those hospitals run at a deficit. They lose money on average. And we can see those significant gaps here, about $500 less per patient day in reimbursement. And that payment policy is a reflection of a political decision to value the care of Black patients less, right? And that's both a political decisions to allow a large portion of our population, particularly Black patients and other patients of color, to be uninsured. And in the design of our Medicare and Medicaid programs, where we have two separate programs, one Medicare that reimburses at a much higher rate, disproportionately for white patients who are more likely to make it to survive to Medicare age, and a separate program of Medicaid for poor patients, disproportionately patients of color. And so, I think my hope here was both to reinforce exactly what Dr. Darity has been saying about the sort of significant impact and the significant possibility for reparations to make an impact on our racialized health inequities that we see by closing the Black-white health gap, or sorry, the Black-white wealth gap in household and individual wealth. And that was the finding of our study. And then also just to emphasize that while we make those, while reparations would close the gap in individual and household wealth, there are other areas where we are failing to invest in the health of Black Americans, and that requires significant redistribution of resources to ensure health equity. So I will leave it there.
Okay, thank you. Dr. Darity has spoken on the case of reparations and the wealth gap. Both are crucial for understanding the public health implications of this topic. As he pointed out, the chronicity of racism and discrimination, importantly, government-sanctioned discrimination, have perpetually crippled Black economic opportunities. I believe one of the major challenges we have today is the inability of many white Americans to acknowledge how they have benefited from the wealth and white privilege accrued as a result of slavery, followed by institutionalized Jim Crow, and what persists today, the ongoing racial inequality and racism. It is common for people to say, slavery was a long time ago, that was another time, and people are different, which fails to acknowledge the benefits accrued as a result and the nation's failure to acknowledge it. While a handful of state legislatures and even the US Congress have issued an apology for slavery, none have gone as far as to acknowledge there is a debt to be paid as a consequence of it. Yet the concept of reparations is not foreign to the world governments or even to the United States. The Canadian government, our neighbors to the north, have acknowledged and made an effort to compensate families for their practice of removing Indigenous children, or as referred to in Canada, First Nation children, from their families, and by placing them in live-in religious schools where they could be indoctrinated in Anglo-Canadian culture and deprogrammed of their Indigenous culture. The German government paid reparations to the families of the Nazi Holocaust. I remember my grandmother, who fled Nazi Germany in 1939, eventually received a monthly check called Wiedergutmachen, to make good again. And yes, our pious US government paid reparations to Japanese Americans who were wrongfully incarcerated during World War II. So it is not a concept with which the government is unfamiliar. The problem people seem to have is acknowledging it is a debt that is still owed and has not diminished with time, but continues to accrue as a result of the disparities that occurred and are ongoing. Dr. Himmelstein, in her work on the structural racism in healthcare financing, references the disparity in reimbursements from Medicare and Medicaid. I want to remind you that Medicare is federally funded and federally mandated. It was the threat of loss of federal funding that resulted in the almost overnight desegregation of hospitals across this country, most notably in the South. Medicaid, on the other hand, while federally mandated, it is state funded and varies from state to state on the level of funding and the level of reimbursement provided for services delivered. Dr. Himmelstein points out that Medicaid disproportionately serves people of color, while Medicare disproportionately serves white people because fewer people of color live long enough to reap the benefits of Medicare. As a matter of fact, it is amazing what happens to healthcare outcomes of Blacks once they turn 65 and receive Medicare. While looking at diabetes or heart disease or renal failure, Blacks on Medicare begin to improve after a few years after turning 65 and begin to mirror their white counterparts in some of their outcomes. There is no question that healthcare outcomes are multifactorial, and access to appropriate healthcare is just a small piece of the problem. But as a public health issue, we must begin to address it on all strata. We have never reached a level of opportunity for people of color in this country as we have for everyone else, including immigrants. The idea that people, including some people of color, believe that Blacks have not achieved as much because of a lack of ambition or drive or work ethic is offensive to me. There are fewer Black men in medical school today than there were 50 years ago. The most striking thing to me when I became the chief medical officer for Cook County was my first clinical chairs meeting. When I looked around the room, I saw almost all white men. We are an organization that prides ourselves on taking care of everyone who comes to our door, regardless of their ability to pay. Now, that is not to say there was a single one of those chairs who didn't deserve to be there. They were all hardworking, smart, and dedicated. But you have to ask, were there no women or people of color who were just as qualified, just as driven, or just as dedicated to our mission? Had any of them been given an opportunity? Who gets to go to medical school in this country? Who gets to go to college in this country? Reparations is about acknowledging responsibility and then about acts of restitution. Dr. Darity references Prince Edward County in Virginia that shut down all of its school system in 1959 rather than comply with the Brown versus Board of Education desegregation decision. The school board refused to reopen schools until 1964. While white students were provided with tax credits and vouchers to attend newly created white academies, no resources were provided for Black students. In 2005, the state finally made an effort to atone for this action by offering victims the opportunity to pursue higher education. 46 years later. What happens to a dream deferred? In this conversation about reparations, we are talking about how the United States begins to make restitution for atrocities that occurred generations ago. It is important to acknowledge, one, discrimination is ongoing, disparities persist, as a result of structural inequities that exist in our society. Two, whether they acknowledge it or not, whites have benefited from the infrastructure created by free Black labor. Three, the reality is to achieve equity, we are talking about redistribution of wealth, which is terrifying to people in this country. Four, we have not even mentioned the indigenous people of this country, Native Americans, or the many Latinos who have also suffered as a consequence of the structural racism upon which this country was built. Finally, there had to be an acknowledgement that slave trade and the benefits of that labor were not only accrued in the United States. There are many multinational companies that benefited in their origins as well. While we are having this conversation, it is not an issue that it is an issue that has been raised since the original promise of 40 acres and a mule following the end of the Civil War. We are unlikely to see advancement in the absence of national leadership and a different tone in our discussions about equity. We are so deeply divided, and white supremacy has again become quite open and blatant. Conversations about equity often trigger cries from certain segments of our society about what it will cost them. The ugly belief that by some whites that if there is equity for people of color, it is at a loss of stature for whites. If we cannot get past the bigoted hatred of white supremacy, we are doomed to destructive strife that threatens us all. I hope conversations like this one will help us to move to another plane. And with that, I would like to open it to questions from our audience. Thank you.
Hello, everyone. Please feel free to raise your hand or type in the Q&A box if you have any inquiries for the panel. Thank you.
Well, Sandy, while we don't, I'm waiting for questions, or maybe one question has occurred. Dr. Darity, can you tell us a little bit more about your reparations proposal?
Certainly. So the premise is that the objective, as I said, would be to close the racial wealth gap. I have invested a substantial amount of time in thinking about the question of what kind of institutional structure would be required to do this. Kirsten and I concluded that one of the most important things to do is to create a vehicle for the eligible recipients to elect the individuals who would be responsible for monitoring the program. We've thought about the reinstitution of something that might be the equivalent of the Freedmen's Bureau for the 21st century, so that the objectives of trying to improve the well-being of Black Americans could extend to other facets of Black life beyond the financial. And so we actually refer to a new agency, a new federal agency, which we refer to as a bureau, as a nod to the Freedmen's Bureau, as something that should be instituted. We also talk about the importance of an educational dimension to a reparations project, particularly because there is, in the present moment, such an extreme opposition to telling the true story of the nation's history and past. And so as a consequence, we think that there should be a component of a reparations plan that is curricular and instructional in the same way as which such a component was introduced into the Civil Liberties Act of 1988, which provided reparations for Japanese Americans who were unjustly incarcerated during the course of World War II. Unfortunately, that component of the legislation, the educational component, was defunded under the Clinton administration. So I think it's really critical to have a similar type of educational component that's built into a reparations plan for Black American descendants of U.S. slavery. But also there needs to be some guarantees and assurances that it would be truly funded. A last comment that I'd make about the nature of the plan is, given the fact that any new government expenditure potentially could generate significant inflation and thereby undermine the effects of that expenditure. I mentioned that we suggested some ways in which you could minimize the inflation risk of a reparations plan. And there are two major ways in which we think this could be accomplished. The first is to spread the distribution of the payments out over a series of years. We don't want it to go beyond a decade, but you could then have a situation in which you were essentially paying out $1.4 trillion per annum instead of the $14 trillion at one time. And also you could create a more diverse portfolio of assets than merely a simple cash transfer. If you also incorporated the possibility of providing people with annuities or trust accounts or some other form of an endowment where the money could not be spent instantly. But the key factor is that the individual recipient should have full discretion over the use of the funds that they receive.
Thank you. There are a number of other questions. One asked about how we could take this opportunity that the window that has been opened by COVID to arouse the social conscience of this country, to get people to think more about reparations at this time. And I think that, Sandy, you can speak to this, but our challenge is we get a lot of talk, we don't necessarily get a lot of action at this time.
Well, I actually think that the effect of the events of 2020, not only the pandemic, but of course, the very visible tragic death of George Floyd, and others that came to light. This is the police executions of unarmed Blacks has been going on for a long, long time. But in 2020, I think people finally recognized or admitted that this was something that had been happening. And I think it has had a major effect on people's attitudes already. If you go back to the year 2000, the beginning of this millennium, there was a study that was performed by Michael Dawson and Ravana Popov, two scholars at the University of Chicago, where they surveyed Americans about their opinions on reparations. And they found at the time only 4% of white Americans endorsed monetary payments of reparations for Black Americans. And then by the year 2018, the figure was closer to 15%. And now it's in the vicinity of 30%. Now, I would argue that the this amazingly hostile reaction to truth-telling in the educational system, this attack on so-called critical race theory, et cetera, is a recognition on the part of the other 30% of the white population that there really is a significant change afoot in terms of people's outlook and attitudes, and they're fighting back.
Correct, correct. And one of the questions was, why do we think that the solutions like reparation haven't gotten more traction in public health and the medical communities?
Kayty, would you like?
Yeah,
Yeah, certainly. I can speak to that. I mean, I think some of what you were speaking about, Dr. Fegan, as well, about the, who makes up the medical community, right? And we're disproportionately white folks. We're disproportionately people with class privilege. And so I think there is a resistance to conversations about redistribution in that setting. I think also, physicians have tended to be, and other healthcare providers have tended to be very individual focused, right? Our training is to take care of the person in front of us and not to think about the institutions where we work, that sort of aspect of the superstructure or the political system in which we live. And so I think that that has been, some of the resistance. And as you said, there's been a lot of talk and not a lot of action since 2020. But I think that, there is a very significant movement for reparations outside of medicine, and something that us, we as healthcare providers can certainly get on board with, both just as people who live in this country who participate in the civil society, but also as people who care about the health outcomes of our patients.
Yeah, and I think that's a very important point in the way in which physicians engage with the healthcare delivery system and tend to be very narrowly focused on the patients or the problems in front of them, instead of seeing it, being part of a much larger infrastructure. Talking about the fact that the funding and financing has structural racism in it. And I look at the organization that I'm a part of, and I can't travel anywhere in the world where I don't run into someone who hasn't heard of Cook County. And yet when I look at what we're able to offer our patients, and I like to believe we offer our patients the best care available, and yet I look at the resources of other hospitals and recognize that we don't have that level of funding, that we have outstanding clinicians, but the resources are not there, and who makes those resources available to those patients. And so physicians are very focused on what's in front of them and not as part of the bigger structure. And I think that it requires huge change, and in terms of who gets to go to medical school, who gets to be in a decision-making capacity. And I recognize that in my role as a chief medical officer for a huge system that employs 1,000 physicians, there's an opportunity there, but there are not enough opportunities across the country to implement the change necessary to change the way in which we think about these problems and look at different kinds of solutions.
Yeah. I think also, one has to take into account issues concerning the training of physicians and what types of beliefs are promoted in the process of their training that may lead them to look at the person in front of them, if they are Black or white, in substantially different ways.
Oh,
yeah,
absolutely. There are so many studies looking at the disparity or differences in how we treat pain, how we address the cardiac needs. It's just been demonstrated again and again. And it does stem from the training. And that's the person who's at the head of the bedside. Every time I walk into the room with a residents and students, and the patient looks up and sees me as the person in the gray coat in charge, I can't tell you how often there's a whole change in terms of the response. So we have a ways to go there. So we have a question about, with the $14 trillion price tag, do we think the government will ever consider reparations? And what can we do to begin that conversation? I think one of the things I alluded to, but Sandy, I'll leave it to you, is that we have to have a change in leadership. There has to be political courage.
Oh, absolutely. We have to have a different Congress, probably have to have a different president for that matter.
Yes, for sure.
Yeah. And I think that that's the whole issue that surrounds building a social movement to make reparations happen. And that's why the fact that today 30% of white Americans actually do support monetary payments as reparations for Black Americans is quite significant, because it creates a foundation to have the type of momentum that could lead us to a position where it would become a possibility, would become something realistic. But yeah, you're absolutely right. There needs to be a change in who our elected officials are.
Yeah, and unfortunately, I think that Barack Obama almost shut down the conversation about reparations before it could really get started as he entered office. You know, John Conyers had a bill before Congress to try to begin that conversation, and we couldn't get very far with it because the Obama administration thought there were other things that were more important to address at the time.
Yeah.
But I think, and the next question is also about that, is that, you know, how do we move to a different spot, you know, in terms of, is there anything that we could do to eliminate the wealth gap or begin to approach that? And again, I think it requires national leadership. You know, it's not that this is something that can be done on a city level, a county level, or state level. It really means that we have to have national leadership with the political will and courage to talk about this on a broader scale.
Yeah. To paraphrase our current Chief Justice, the way you eliminate the racial wealth gap is by eliminating the racial wealth gap. I don't think that there's any other alternative approaches other than a direct distribution of resources that will have any significant effect on closing the racial wealth gap. You know, people frequently talk about indirect measures like improving education. And of course, as an academic, I'm passionately committed to people improving their educational position, greater educational attainment. But that has very little effect on the racial wealth gap. One of the most disturbing statistics that we've come up with in the research that we've done is that we found that Black heads of household with a college degree have 2/3 of the net worth of white heads of household who never finished high school. People frequently say that something like student debt relief will close the racial wealth gap. But if you really run the numbers, you'll find that if you're looking at the gap at the household level, the average level that I've talked about, approximately $840,000, eliminating student loan debt will of course have a tremendous effect on reducing people's anxiety and improving their outlook, making them healthier in terms of their mental health. But if we're thinking about closing the racial wealth gap, it would reduce the racial wealth gap by less than 1%. And so I think that you've got to take the bull by the horns, as they say, and be direct about trying to eliminate the racial wealth gap, because otherwise you won't.
Yeah, and I think that what people don't understand here is even as people of color accrue wealth at this point, there was nothing that was handed down. You know, that there's over time, property was initially the thing that was handed down from family generation to generation, and that trying to catch up, you start from so far behind that it is not just the, you know, on an individual level. We have to look at society as a whole. You know, all of those years where Blacks were not allowed to take advantage of the GI Bill to the same extent that their white counterparts were, where we had restricted covenants and then we had redlining, and the Blacks were not allowed to acquire property in parts of society or of their town that might have resulted in something they could have handed down to the next generation. That starts you so far behind that the simple efforts of a single individual going to school, getting a degree and accruing doesn't begin to scratch the surface of the generations that have been deprived of the opportunities.
You know, one of the things I mentioned was the Homestead Act of 1862 as a foundational moment for building white wealth to the detriment of Black wealth. And I think that Trina Shanks-Williams at the University of Michigan has estimated that there are 45 million living white Americans who are continuing to be beneficiaries of the Homestead Act land patents.
So the question is, there have been many injustices done to people in the past, and what would be the vehicle for reparations to go forward in promoting health equity? You know, I think that promoting health equity at this point, you know, is trying to ensure that we provide appropriate funding for the care of patients. And as long as we have this huge disparity from state to state in terms of Medicaid reimbursement, and that the people of color are dependent upon the healthcare reimbursement from Medicaid. So it's really addressing that whole issue. You have a federally mandated program that's implemented differently. It's the same thing as why we were allowed to, Jim Crow was allowed to persist in some areas of the country far longer than other parts of the country. So it's beginning to address the disparities that we create with Medicaid that really go from state to state.
Yeah. I would like to ask if Kayty would talk about the mechanism that links lower wealth to lower health. I'd like to mention that in the other study that I talked about, where an attempt was made to gauge how much the COVID-19 transmission rates would have been reduced if we had no Black-white wealth gap, the underlying mechanisms are twofold. One is the transmission rates are higher in the absence of a racial wealth gap because of the high density and low quality of housing that Black Americans are exposed to relative to white Americans, but also because such a significant portion of Black Americans who have employment had employment in jobs where there was a high degree of contact or exposure to the disease. And so if you had reduced the racial wealth gap, you would have had a different occupational profile for Black Americans, and you would have had a different housing profile for Black Americans. But, you know, Kayty, I'd love to hear your thoughts about what the relationship is to overall mortality.
Certainly. No, I think I'm, as an infectious disease doctor, I think you've named two very important mechanisms for infectious diseases: housing overcrowding and sort of lack of occupational flexibility, right? Or the ability to remove yourself from an occupational risk. So I think that that's extremely important in the setting of infectious diseases. I think, you know, wealth, as you mentioned, wealth is sort of qualitatively very different from income in providing security and sort of continuity, whether that's continuity of housing, continuity of food, stable supply of food. So I think, you know, I think that the specific mechanisms linking wealth to health really are not well studied, but I think that all of us who care for patients and live in the world understand that greater flexibility, greater security, and continuous access to the resources that we need to thrive, whether that's housing, food, you know, safe places for recreation, are really key inputs that lead to better health.
Yeah, so many of us have already recognized health systems across the country. We have a division of housing at Cook County, and many health systems do, and now recognize that food insecurity is such an important part. And so screen our patients for housing and food insecurity, and actually try to provide stable housing for patients who will benefit in terms of their health. I want to go to another question that said, is it possible to have reparations limited to the US? Is it not essential, considering the challenges of climate change, to have international approach to address the impact of colonialism?
I think that's a different reparations project. By all means, let's pursue it, but let's not pursue it at the expense of a commitment, making a commitment to a debt that's been owed for more than 150 years.
Yeah.
I would also like to say there's some fantastic comments in the chat. I've really enjoyed looking at them. Suggestions about different types of language to be used, like the social determinants of death rather than the social determinants of health. So great comments in the chat. So thank you.
Yeah, I know. I'm going to get
Yeah.
like a little sensory overload trying to. So if we think about, the next presidential election and a new presidential term in 2024, what concrete steps do we think can be taken to potentially achieve this before January of 2024? In other words, it's a litmus test, right? To have that conversation with people who are interested in office, in public office, about their thoughts on this.
Yeah.
I don't think it's something that we talk about enough, and you have to have more conversations so that you have people who run for office who don't feel obliged to even comment or have an opinion or have given any thought to it. Yeah. Okay. Is there a strategy or a specific plan to create policies to make this possible? So what plan is politically possible in the state of the current polarization and post-truth? I think, this is a sort of like our throw up our hands and say there's nothing that can be done, that things are too polarized at this point. But I think by virtue of the fact that we're having this conversation today, and that there's so many people who are on line to engage with this is an important step forward, and that we need to have more conversation.
And the change in attitudes, as I said, is a factor that has contributed to the polarization. So do we want to avoid having this kind of conversation and confrontation because we're afraid of polarization? I mean, the most extreme moment of polarization in this country was obviously the Civil War. And it was a product of the actions of individuals whose descendants are central actors in the polarization of the present moment, including the invasion of the Capitol on January 6, 2021, rather. Yeah.
We're drawing to a close, but Kayty, I can't resist asking you this. Your proposal for redistribution of health resources is intriguing. Would universal health insurance, presumably supported by progressive taxation, suffice? And how could we specify the details to create better resource availability beyond health insurance and healthcare facilities, institutions that would come under tighter moral control?
So certainly I agree. I think a single payer system would be a strategy for reducing or eliminating the inequity in health reimbursement. It would not eliminate the existing capital inequity. So what you described, Dr. Fegan, about the resources at Cook County versus the resources at neighboring hospitals, that would not go away simply by equalizing payment. So I certainly think equalizing payment is an important first step, along with a concerted policy of investment in hospitals that serve Black patients to ensure that they have the resources they need to provide good care for their patients.
Right. I always like to point out that, providing access to care is just the first step, to have that conversation, that single payer is a financing conduit. But the bigger question is, how do we provide access to who doesn't deserve the best care, right? And what is the quality of care that we provide to everyone? So we're at the end of our time, and I want to say that this is a series of conversations we're having. If this was useful or beneficial to you, I invite you to join us again on October 20th, where we will have a discussion about the Supreme Court assault on health. And that will be October 20th. It'll be 11 a.m. Pacific time and 2 p.m. Eastern time. And I hope that some of the folks who joined us today will come back for that conversation because this is an ongoing dialogue about equity and justice in healthcare. So thank you very much for your participation. And thank you all for joining us today.
Thank you.